my name is Allison Phelan Egan, and I am here with my oncologist, Dr. Decker.
Hi.
Hi. So when I came to see Dr. Decker, I was in really bad shape, and he hooked me up, literally. He hooked me up, get it? And I remember...
sense, but okay. But okay.
I remember the chart was to the side, and you hadn't come to see me yet. But I read it. I peeked in it. I wanted to see what's going on. Most of it I did not understand, except the part where he said that I was pleasant. And I said, oh, no, I want some more colorful description words.
Right.
You gave me some, but I have chemo right now. I don't remember. You have to refresh my memory.
No, we'll just leave it at that. You know,
okay.
That's why somebody else may pick up the chart. You have to be careful what you put in there.
Yeah. I'm like, pleasant? That's so boring. I'm just pleasant. But you said, I think you said I was young. And something like almost healthy. Pretty 95% healthy.
Yeah. Or generally healthy. Right?
Generally healthy. She has cancer, but she's generally... No, it was out by then. It was out.
Yeah.
Okay, so what is an oncologist?
It's a cancer physician. And there's actually, within that, I'm a medical oncologist, so that's a subspecialty of internal medicine. There's surgical oncologists, and there's radiation oncologists, and then the medical. And we try to provide an overview of how to treat cancer. When it requires surgery, we send the patient to a surgeon. Radiation, we send out as well. If there's medical treatment, chemotherapy, and these new targeted therapies, then that's what we supervise directly.
What is chemotherapy in the simplest form? Like, how can you explain what chemotherapy is? Chemical therapy,
right?
Chemical warfare with your body, right?
I think back in the early 20th century, that actually applied to antibiotics, and then they came up with antibiotics. So that term was hanging out there, and in the late 40s and early 50s, using chemicals to kill rapidly growing cancer cells. They adopted the name of chemotherapy, and that's kind of what it is. It's various medicines, various chemicals that interfere with the growth of cells, and they're not as specific as we'd like them to be. So they're mostly playing on the fact that cancer cells are growing more rapidly than healthy cells. So if you're throwing a compound that interrupts DNA synthesis, basically the replication of the cell, it may have more of a direct effect on the cancer cell. That's why other cells that are rapidly growing, hair or white blood cells and so on, would be more exposed to the toxicities and more likely to show the side effects of that class of drugs.
It's kind of like, I just had a visual of like a superhero and a villain, and cancer's the villain.
Absolutely.
And it's like going, and we need the superhero to come in and like kick it.
Right. You got it.
That's my visual. So when I first started doing chemo, I started hearing the term chemo cocktail. What does that mean? Or maybe that's just a word amongst us.
So
that's not. He doesn't use that word, but
right.
They'd be like, "Oh, what's your chemo cocktail?" I'd be like,
right.
"What does that mean?"
Well, so it's a combination.
Yeah.
Because there's probably, I'd say 50, 60 medications or more that fall into this heading of chemotherapy. Now there's these new targeted therapies, but let's talk about chemo. When you have a more serious infection, the doctor will give you more than one antibiotic. I mean, you get a simple bronchitis, you get one antibiotic. Come into the hospital with serious pneumonia, you might get 2 or 3 antibiotics because no medicine is 100% effective, whether it's eradicating infection or eradicating malignancy. So when we look at, let's again say colorectal cancer, and there's maybe 8 or 9 drugs that they will more commonly use in that diagnosis, one drug, might be effective for 50% of the people. So we combine 2 or 3 and hope that we get as close to that 100% response rate as we'd like. In reality, the modern combinations are effective about 70-75% of the time for a particular patient. So, and if our initial combination or cocktail is not effective, then we go for cocktails, and then we think it over and
reevaluate.
we change to call the bartender, and we get a different combination. That's what
I think they invented that term for us to make it sound more festive.
Yeah, a little more appealing.
A little more appealing. Would you like a chemo cocktail? Where did these chemical drugs come from, and why are they so expensive? What is that?
So, there's actually an interesting history on the development of chemotherapy dating back to the Great War, but mustard gas, when this exploded in a shipyard, that the sailors and soldiers that survived or didn't, they noted that there was wiped out their lymphoid tissue. So they said, oh gee, this nitrogen mustard is toxic to the lymphocytes, the lymphoid cells, and that's then when Sidney Farber and his group in Boston back in the 1940s then said, well, let's try some of these drugs, and they also had the methotrexate class of drugs, and they started to show that giving incrementally larger doses up to a tolerable amount of these drugs would effectively kill some of these leukemic cells. Mm-hmm. In fact, why is it hematology oncology? Because the hematologists were treating leukemias, and back then, kids and adults died in days or weeks. We didn't have platelets and blood transfusions and modern antibiotics, much less the chemo. When lung cancer and colon cancer needed to be treated, the surgeons said, and the pulmonary docs said, I'm not treating lung cancer with those poisons. The hematologists are using the poisons, let them treat it. And so that's why medical oncology came under the purview of the hematologists. And,
I see.
And so that's how the specialty developed. Then as we understood more about the chemistry of the cell, more and more drugs that had different areas of attacking the cell nucleus had been developed. And again, we, through methodical clinical trials and so forth, developed drug after drug that seemed to show some activity in killing off various types of cancers, and led to the approval of all of these new drugs that we have today. The newer drugs, absolutely, are the cost is out of sight. It's or charges, I should say. Cost is a different concern. There's too much profit taking on the side, but that's an editorial statement. With the advent, as we've said about gene analysis, genome sequencing, we're learning more about the cells and coming up with better, more specific drugs, and it's pricey investigation, research, and trials, and cost of healthcare just continues to spiral up. Mm-hmm. But it's actually had some. These newer drugs have had some dramatic impact on cancer, though.
It's good, really good.
Yeah.
Why? What are some of the side effects of chemotherapy? I could list them, but I'll let you.
The generic side effects that most people think of would be nausea, vomiting, hair loss, feeling sick, low blood counts. I mean, a lot of that relates to you're killing these rapidly growing cells, the hair cells, the white blood cells, the lining of the GI tract, all of that's growing faster than other cells in the body. Then there's things that are unique to the class of the chemotherapy. So, the platinums and the taxanes can cause neuropathy, where they damage the nerves gradually, and the finest nerves are most sensitive. So the sensory nerves out to the fingers and toes, are the first to be hit, and so you get numbness and tingling in the fingers and toes.
And throat.
There we go. Well, that's the cold sensitivity too. Class of drugs called anthracyclines is toxic to the heart. You get too much of the drug, and you can go into heart failure. Cisplatin, too high of a dose or improperly given, can damage the kidneys. So, as drugs get developed, optimal dosing is evaluated, and when toxicity is encountered, you back down on the dose. And then you try to combine drugs when you do these chemo cocktails or combinations. If one is damaging potentially the kidneys, you try not to use it with another one that's damaging the kidneys. You want to mix up the toxicities so that you try to minimize the damage. We really try to minimize that collateral damage, if you will. The newer targeted therapies, it depends on what the target is. Because they're targeted, there should be less toxicity. It's going to be more toxic to the cancer cell. But one drug that we use in lung cancer and a related drug that we use in colon cancer targets a gene called EGFR, epidermal growth factor receptor. And that's driving the cells to grow. But as the first word implies, epidermal, that's the skin. So not only does it attack the lung cancer cells or the colon cancer cells, but it attacks the skin. So those patients get a skin rash. And skin rashes are a common side effect of a lot of these newer targeted therapies. Now, in the last couple of years, we're looking at ramping up the immune response to cancer and unmasking the cancer cell to allow your body's own immune system to attack. And that's now novel therapies that have really led to some tremendous breakthroughs in melanomas, and now we're using those in lung cancers, kidney cancers, and exploring other cancers as well. And if we can really get the immune system to target the cancer cell, that'd be great. But already we're seeing some of the toxicities would be that the immune system's overactive and attacking, your liver, your skin. We have to moderate that effect. So again, it's having an understanding of where that potential toxicity is, when to look for it, what to do about it if the patient develops it, and we try to moderate all of that. That's all part of managing the patient.
Yeah, you do that well.
Thank you. You're living proof. Okay.
I am, because I remember you lowered my dose because I was so messed up, and then I was worried. I'm like, well, am I going to get enough? And you're like, yeah, because you need enough. You don't want the chemo to kill you.
So that's an important point. We actually hate to underdose somebody.
You didn't underdose me.
And we don't intentionally. In fact, you get 100% dose until you get a specific toxicity. If you look at how these clinical trials are developed, if somebody's blood counts keep getting too low, she's got to get a 25% reduction because of such and such a parameter. If there's a toxicity, if there's a neuropathy that's too severe, you actually stop that drug and you substitute a different drug. But it's all kind of by the book. It's not, I think she should probably do well with 50%. No, it's when you're delivering curative treatment, you always start at 100%, and and if somebody doesn't have trouble, by the way, you don't punish them and go to 150%. 100% is the max. You can adjust down if certain criteria suggest that that's too toxic.
Like a chemo sale. 25% off this week.
This week. It's good news. Exactly. Good news. We're cutting you. So, exactly.
Because ultimately, and I think most people know this, is that when you get the chemo, it kills the good cells and the bad cells, which is that's why you're getting so sick.
Yeah.
Right.
Exactly.
That's pretty simple.
It's causing it's collateral damage again. We know that some of these drugs, not even just killing cells, but they go to a place in the brain called the chemoreceptor trigger zone, and that'll stimulate the nausea pathways. There's certain antibiotics that cause more nausea than some of our chemo drugs, but so it may not be direct toxicity on the organ, but it's interesting to understand, the physiology, the mechanisms, how that's affected, because that's actually how they then develop new classes of anti-nausea drugs to counteract that and target the same center and block the effect of the noxious effect of the chemo. So.
Well, my least favorite chemo drug is oxaliplatin, and that was very painful drug.
Yeah, it's a
hardcore one, right?
It's hardcore. We use it a lot, and it does have a cumulative toxicity. It's pretty well tolerated for a few cycles, but by the time you've gone past those first few, then it starts to get laborious. And when we're completing a course of therapy with that drug, everybody's happy to finish.
Yeah,
for sure.
Yeah. On your third round, you're not wearing glitter anymore. You're just trying to get here, get in, get out.
Right. Keep your head down.
Keep your head down. How important is hydration after chemo? Because I'd come in, I get my chemo, take a day off, and then I'd come in the next day for hydration.
Yeah.
That helped me a lot.
Yeah, absolutely important. One of the, I think just in general, but when you're on a treatment, you just feel weaker when you're poorly hydrated. And, I say that our patients are already kind of challenged with, being treated for the cancer, having various side effects. I think when when you don't have any active medical problems, you skip lunch, fine, no problem. You don't drink enough fluids, fine, no problem.
Right.
But when your blood counts are low, when you're not functioning at your best, getting somebody's volume status up to a good level is a good contributor to restoring his or her energy levels. Blood counts will be low as well, but definitely hydration is important on many fronts.
I remember somebody telling me, drink anything, drink Coke, drink whatever, just drink something, get hydrated. And I did, but when I would come to actually get it infused, it was like I could feel the difference.
Yeah.
Definitely helpful.
Yeah, we are a little more specific, but absolutely. Same's true for calories, because if patients are losing weight,
Oh, yeah. Eat
they'll sit down
you
and
want.
go, well, I'm trying to keep that, that high fiber, low protein in them going, just,
Forget it.
If you want French fries, it's fine.
Yeah, eat
just
it.
get the calories
Yeah.
going. We'll worry about where you get them from later.
Yeah.
My nutritionist is going to be really upset that
Yeah.
I said that. But,
this is your chance to eat and drink whatever you want.
Right. Until you start to get back in positive balance, then we scrutinize where you're getting those calories. But keep outside of everything that the oncologist does and the physicians are doing, the patient's role is to maintain decent activity level and maintain decent oral intake, so calories and fluids. Because patients are always asking, great, you're going to make me better, but what do I need to do? So those are the things that we ask of the patients. Because if you're going to lie in bed all day and you're not going to eat and drink well, chemotherapy, targeted therapy, it's not magic. We need the patient to maintain his or her health and be a partner in this treatment. And that's something we really, kind of encourage the patients to participate with.
I did.
You did. And look at you now.
Look at me now. Speaking of that, since we are such a vain society, I think most people think that any chemo drug is going to make you lose your hair. That's not always true.
No. In fact, many of the newer drugs spare much of that hair loss. Exactly. In fact, patients, presume that that's going to be the case. And I have one lady in particular. I usually tell people what's going to happen, and so she was going to start chemo the next week, and I told her, I said, your counts will be low, and maybe nausea, whatever, neuropathy. Didn't say anything about the hair. So she comes in the next week, and she buzzed her hair.
Oh no!
And she didn't shave her head, but it's like short. It was down like 2 inches. And
you're like, what?
And I looked and I said, I like the hair. It was very nice on you with that. And I said,
By the way,
who told her she was going to lose her hair? No, so she was. It was very simple for her to take care of her hair during that time.
Oh
but
my gosh,
that was one that we kind of looked back and chuckled. I guess you tell people what to expect, and you have to tell them what not to expect.
Oh, yeah.
No, you don't. But we usually the people I tell them when they're treatment that they're not going to lose their hair. They usually have hair like mine, and
they don't.
We look at each other and we go, too late. So anyway.
That's so funny because my first two questions, as I've said before, was one, what about my ladies' night? So I ended up getting my cocktails, so that was covered. And then was, what about my hair? And she said, your hair's going to be fine. And I'm like, it did get a little thinner, but it wasn't anything. Thank God I didn't shave my head. No to everybody. Wait, ask your doctor first.
Good point. Exactly.
Oral chemo versus intravenous chemo, obviously, it's more effective.
The one oral chemo that we have for colorectal cancer, which we also use in breast cancer, which is capecitabine, is actually very effective compared with the IV counterpart. Sometimes we're a little uneasy, like, will the patient be taking it right, and will she be absorbing it adequately? So we kind of fall back on the IV, but actually a lot of studies have suggested that drug orally is very effective.
Really?
The problem is there's very few drugs that have a oral form that's useful to us. I mean, some of the blood disorders, they're oral, and for brain tumors and some lung cancers, there's an oral chemotherapy. But when we get down to most lung cancers, stomach cancers, breast cancers, no, the chemo is going to wind up being IV. Breast cancers, there's a lot of hormonal blockers that we'll use all oral medications for. Some of the targeted therapies, again, for about 15% of lung cancers and so on. Those are pills, but true oral chemos are not too common, but useful when it's the right diagnosis and the right situation.
Okay, good to know.
Mm-hmm.
In your opinion, can you beat cancer with Eastern medicine?
There's Eastern medicine's been around for a couple of millennia, and there's some basis in fact, or just in empiricism, that leads to some benefits. I have a lot of patients. Let's just put it this way: about 50% of patients in large surveys are known to utilize alternative or complementary medications, either with or instead of chemotherapy. I've had a few patients that over the years that have kind of flat out refused to accept Western medical recommendations, which are as much as people who have a tendency to be suspicious of society would view that it's all a conspiracy by
Big
the
brother.
pharmaceutical. We've already cured cancer, but we're making too much money treating it. That kind of
I
mindset.
had somebody say that to, are you sure you have it? I'm like, yeah, I'm sure.
I didn't get that
I
memo.
have.
Nobody told me to keep it a secret.
Are you
Nobody
sure?
told me we had the cure. So it's kind of a shame. I've actually had a couple of patients that have flat out refused, including a very highly treatable testicular cancer patient. And you just wonder about how these people are programmed. But then there are various religions that won't accept, whether it's medicine or whether it's blood or whatever. And we're not here to impose our will and insist, but simply to educate and make recommendations. But it is frustrating when there's something that's tried and true that you can't convince a patient has an appropriate use for his or her illness. So I mean, again, but to answer your question, I'm a practitioner of Western medicine. I try to keep an open mind. I know that a lot of drugs that ultimately wind up in the Western medicine pipeline had their roots in Eastern medicine or in alternative therapies. As I like to say, if an alternative therapy actually has some true benefit, it's not alternative anymore. The pharmaceutical company grabs it, purifies it, and charges $10,000 a dose, and you're getting it. And you're getting it. But so that's what we really trust. And unfortunately, there's actually also some recent studies that have suggested that patients that are using alternative or complementary therapies or supplements are having actually worse outcomes than patients.
Reverse effects.
Because I'd be pretty liberal in the past. Say, you want to take this, that. I don't want to name products, but and then there's some legendary products as well that have no real proven benefit. But okay, if it's not harmful, fine, take it. Some of these probably are harmful, and I know recent analysis, supplements are not regulated by the FDA. When they actually studied what's in the supplements, something like 90% of them were not what was supposed to be on the label.
Wow.
I mean, you're getting wheat germ instead of curcumin, whatever.
Right.
So it's not doesn't have the stamp of approval of the government agencies. But anyway, for a variety of factors, those alternative therapies have never really been borne out to be beneficial. So I wouldn't endorse them.
Well, I mean, when you get cancer, you're frantic, you're scrambling, you're trying to find everything. And there's even things on the internet that say, you know, this will cure your cancer. And I would come to you and I'd be like, what about this? And you'd be like, and I, what about this? Like, I would come with my own little special things. And you're like, well, if you want, like, eating lemon rind, I like that. It's like, I heard that will, like, help you never get cancer again. So I'm like, eating lemon rind. And you're like, go ahead, eat the rind.
Eat your lemon rind.
Live it up.
Yeah.
Get your cocktail.
I was gonna say, put a little gin in it, and then you've got something. But yeah, I have a lot of patients that download reams of information from the internet. And,
be careful.
Yeah, it is. There's a boatload of research going on out there in bona fide labs that are looking at compounds and that, you know, again, target the cancer cell that have potential significant upside, and that's certainly where I put my faith. And
mine too.
Okay.
I'm not going to gamble. Oh, let me try this. Maybe it'll work.
Exactly.
Not a good idea.
Yeah.
Last question. Do you consider chemotherapy a cure?
For a lot of cancers, it is. For a lot of cancers, it's dramatic. For a lot of stage 4 cancers, that have spread to other organs, they're not curable, and at least not by standards today. I mean, it's again getting back to the billions of cells that are there and just the effectiveness of the treatment that we've got. And so the best you can do is reduce the cancer, knock it down, improve the patient's prognosis and survival, and hope that the patient's able to hang around long enough to maybe benefit from a new targeted therapy or something of that sort. But it's exciting when patients with early or even advanced stage 4 cancers have these dramatic responses, or when you come across a cancer that is known, whether it's testicular cancer in men, ovarian cancer in women, or even more advanced disease, has a decent or high cure rate for testicular cancer, say. And obviously lymphomas and the like, but too many cancers are just not sensitive enough to modern, therapy, and so it's just a question of time. It might have been 6 months in the old days, and might be 2 or 3 years today that the prognosis has evolved, but that's why we're still at it, trying to do better, find some new things, and improve patient outcomes further.
I'm cured.
Knock on wood. I was never superstitious till I became an oncologist. But
knock on wood, get the holy water, pray. I like pray to everybody.
Absolutely. You got it.
Cover all my bases. So when I come in to see Dr. Decker, which is every 3 months now, I've put in my calendar coffee with Dr. Decker, because first, I don't like to have any negativity about meeting with him about, my numbers, and so far they've been really good, and I have a lot of fun with visiting my doctor.
Yes, we do.
We do. Thank you so much. It was pleasant. It was a pleasant interview.
It was great. And painless too.
Painless.